Hello all, myself Dr. Gayathri Bhat, Professor, Department of Prasuti Tantra and Stri Roga, SDM College of Ayurveda and Hospital, Hassan, Karnataka. Today I am going to explain about episiotomy. You are going to get knowledge about episiotomy skill, and after the this lecture you will be able to have an idea about how to perform the episiotomy and how can we manage and prevent the complications. So episiotomy is the common obstetrical operation. It is done to enlarge the vaginal introitus and to prevent the tearing of perineum at the time of labor, during forceps and venous delivery, and if a patient is having history of previous pelvic floor repair as well as perineal reconstructive surgeries, in such cases also during labor we may have to give episiotomy. So it is a planned surgical incision given on the perineum at the end of the second stage of labor, that is during crowning of the head. Mainly the types are medial, lateral, mediolateral, maybe right or left, mediolateral, and the J-shaped. Very commonly performed is right mediolateral, that is RMLE. So whenever we perform the episiotomy, we should know what are the structures we involve. So here posterior vaginal wall, superficial and deep transverse perineal muscles, bulbospongiosis and part of levatrani muscles are included. Along with that, perineal branches of pudendal vessels and nerves and the subcutaneous tissue and the skin are also involved. When we know what are the structures we are involving while performing the episiotomy, it is helps us to prevent the injury of other structures surrounding. Then episiotomy is performed at the time of crowning of the head. The surgeon should introduce the index and the middle finger of her hand to in between the head and the perineum. Then before we perform, we have to give local anesthesia also to the perineum. Then using the episiotomy scissor, the episiotomy should be given. So how to repair? Repair should be done immediately after the expulsion of the placenta. From first we have to identify the apex of the wound. Then we have to, using the chromic zero catgut, we have to suture the vaginal mucosa and the submucosal tissue by continuous interlocking sutures. And that suture should end at the muco-subcutaneous junction at the level of perineum. Then next step is suturing the perineal muscles. You holding the perineal tissue muscles with the forceps, toothed forceps. The perineal muscle should be sutured by the catgut by interrupted suturing. Then after suturing the perineal muscle, skin and subcutaneous tissue should be sutured using the matrix. So after suturing the perineal episiotomy wound, we have to check for any leftover bleeders. If it is there, then that also should be ligated. Then it should be cleaned with the antiseptic solution, and it should be dressing should be done. And every day the dressing of the perineum, episiotomy wound should be done. Even the SIDS bath with the Panchavalkala Kvata or the salt water or the hot water SIDS bath also can be advised. And if the episiotomy is extended, it becomes a major complication. It may include the posterior vaginal fornices deeply, and it may even include the rectum. It may injure the rectum, and sometimes there also may be hematoma formation, and the hygiene is not maintained, care is not given, infection also may happen. So rarely wound adhesions, dyspareunia and scar endometriosis also may be the complications of this episiotomy wound. So episiotomy is usually done in primipara, where there is a rigid perineum, and very importantly post-operative hygiene and care should be there to prevent the further complications. And for the episiotomy to perform, the skill is very important. Thank you. You can give your feedback so that it will help us to improve our next lecture.